Please. Good morning. Thank you for coming so early on Saturday, but I must, those who think it's too early, the group started here at 6:30. Another group for a special function from us. They are the early bird, and they really were in excess of what we expected. Anyway, I hope today we'll have another great session like the one we had yesterday. Some of the people here today were not in yesterday, and we'll try to present them to you. However, I would like first to remind you, first we have this formal session all day today till 5. At noon, there will be two luncheons. One on echocardiography with the world expert, Dr. Tony DeMaria, who is the one who wrote the book on that, along with Dr. Dolan, who will be in a side room. Then in the main room here will be a talk on the latest and greatest drug to reduce LDL cholesterol, BCKS9, from the governor of the American College of Cardiology, state of Florida, will be here. Now, I'm also pleased to tell you that all the faculty are here and awake and will introduce to you later on. Now, I would like to take this opportunity again, like yesterday, to thank Memorial Hospital, Memorial Healthcare Foundation for supporting this program, along with all the people who supported the program, which I acknowledged yesterday. Now, I would like to introduce to you the CEO of Sarasota Memorial Hospital, David Verinder, who is behind the scene for all the success we have at this great place. David?
Good morning, and thank you, Dr. Shahawi, for inviting me again this year. It is always a pleasure to come out to your event and get to welcome people. I think this is, I forget how many years it's been, but it feels, well, it's been 13 for me, so I appreciate that. And I want to just take a second and welcome everyone that's coming from out of town to our beautiful city. I think it's, well, we're biased. We think it's the best city in the world. And since it was 50 below in Chicago this week, I think everyone else agrees too, right? So hopefully you will not be in here listening to lectures the entire weekend. You have a chance to go visit the beaches and the scenery around. No? All right. Sneak out the back, go see a beach, anyway. I will tell you, Sarasota Memorial has long been a leader in providing advanced techniques and treatment for heart patients. Our cardiac team, which has been recognized among the nation's best, has decades of experience treating high-risk patients with complex conditions. This past summer, our program was the first in Florida and fourth in the nation to be designated an American Heart Association Cardiovascular Center of Excellence. We recently were one of only 3 programs in the U.S. and Canada to earn the highest 3-star rating from the Society of Thoracic Surgeons in all 5 of the adult cardiac procedures publicly reported by the national organization. Just a few months ago, the American College of Cardiology gave its highest level of designation as a chest pain center. Because of our proven track record, we have become the go-to hospital for cardiac care and perform more than 1,100 cardiothoracic surgeries annually, reflecting our role as a regional referral center. And I will tell you that number has over doubled in the last 5 years at SMH. Our patient-focused cardiac care doesn't end at the hospital's doors. We also offer disease management and prevention programs to help people stay healthy and a full range of rehab services to help patients regain their quality of life. Once again, we're very proud to be able to come in and welcome you to this area and to our city. Dr. Shahawi, thank you again for taking, I know this is an inordinate amount of time, effort on your part to do this, and our community is grateful as well as everyone here. So thank you. Okay.
Thank you, David, for your kind words. Now, I know that past chairman of the board, Gregory Carter, talked to you yesterday and greeted you. Some of you are not here. I promise he should greet you. He's not talking about the good things he said about me yesterday. Okay, Gregory? It's up to you, but I appreciate your all kind words. Please come on and That's the first chairman of the board who some of you haven't seen yesterday, and current member of the board, and I've been doing a great job for 12 years on the board and paid position. Can you believe that? Thank you.
Thank you, Dr. Shahawy. I'd like to welcome everyone here today. For those of you that have come in from out of town, I like to consider this the polar vortex of Sarasota. So this is a little bit different environment here. So welcome. As I spoke yesterday, I take this from a personal standpoint. When I came here 17 years ago, I was looking for a physician because I have a family history of heart disease. And I chose Dr. Shahawy. I've been with Dr. Shahawy, a patient of Dr. Shahawy's for all that time up until today, unless he kicks me out today. So,
good things I will not kick you out.
Okay. He's always emphasized to his patients and to me, and I've taken it to heart, so to speak, about prevention. That is one thing that he has always expressed to me that's extremely important. And that's what this Congress is about. And I'm really happy to see all of the folks here today. This is a very important thing. I participate in his assessment program. Every few years we go through and do an assessment. I just did one in December. And I think that keeping an eye on things and this prevention, I'm an example of how that works. My blood pressure is under control. Cholesterol is good. So I'm a very big advocate of this prevention. And today's presentations will bring that out. It's very valuable. I'd like to thank all of you for attending, and also Dr. Shahawy, Dr. Cohn for putting this together, and all the faculty and the speakers that will be here today. This is some very critical and very important information. And again, I welcome you. Glad you're here. Thank you.
Thank you. Now you're going to hear from Dr. Nanette Wenger, who is the mother of all cardiologists, as I said yesterday. And she trained actually most of our cardiologists in town here were trained by her. So she is who in the world of cardiology, and women's heart disease have been her passion, and she has been sharing everything. And the American Heart Association crowned her 2 years ago with the gold medal for her work in this area. She's a great teacher, great clinician, and great friend. Thank you, Lynette, for supporting this program.
Good morning again. It's my privilege to talk to you this morning about hypertension in women across the lifespan. And I think it's something that we don't consider essentially changing with time, but I will show you that it does. These are my disclosures. And what I want to do is to have us understand the adverse pathophysiologic consequences of hypertension in women, and to appreciate that there are unique aspects of hypertension at different times in the lifespan of women. Background, as you've heard previously, is that hypertension accounts for 1 of all 5 deaths in women, and I will show you it presents a greater disease burden for women than for men. Because compared with men, the hypertensive woman has more left ventricular hypertrophy, diastolic dysfunction, typically more commonly heart failure with a preserved ejection fraction, increased arterial stiffness, more associated diabetes, and more chronic kidney disease, and presents different concomitant issues across the lifespan. We can define hypertensive heart disease in contrast to hypertension. Hypertensive heart disease involves structural and functional cardiac changes that are caused by uncontrolled hypertension, and those are left ventricular hypertrophy, concentric remodeling, and enlarged left atrium, and that will become quite important, as you'll see after a while, reduced systolic or diastolic left ventricular function, and reduce long axis function, essentially global longitudinal strain. What we tend to see, and these are going to be pathophysiologic comparisons, women and men, and without going into too much detail, for any given level of blood pressure, women have more LVH, and with control of that blood pressure, they have less regression of that LVH than do their male peers. Abdominal obesity appears more important as a risk feature for left ventricular mass in women than in men, so much more dangerous in increasing left ventricular mass. And even during antihypertensive therapy, in the course of antihypertensive therapy, when men and women had serial echocardiograms, even during therapy, women developed more left ventricular hypertrophy. You know, women typically have less cardiovascular risk at any given age than do men. But if there is left ventricular hypertrophy in women, that offsets the sex-related benefit for cardiovascular disease. So left ventricular hypertrophy is really a bad thing, both for men and for women, but particularly so for women. An enlarged left atrium, as I've suggested, is more prevalent in hypertensive women than in hypertensive men. And hypertension is a common cause of atrial fibrillation, but only in part related to that enlarged left atrium. So hypertensive women more likely to have atrial fibrillation than hypertensive men. And the systolic blood pressure seems to be the villain. It is the elevated systolic rather than the diastolic pressure that seems to impart the risk for atrial fibrillation. Now, you know, men and women share the same risk factors, but different risk factors are more prominent for women and for men. And this is a study from Tromsø that shows that for acute myocardial infarction, systolic blood pressure is a stronger risk factor in women, and for myocardial infarction, cholesterol is a stronger risk factor in men. So again, hypertension, very bad for women. And the conclusions of this very rapid run through pathophysiology is that hypertensive heart disease, the structural and functional consequences of uncontrolled hypertension, is more prevalent in women. It's less modifiable even during antihypertensive therapy. It offsets the lower cardiovascular risk in women, and very important modulators are obesity, arterial stiffness, and inflammation. Now, what is it that puts women at risk of developing hypertension? Because we should, in theory, be able to prevent hypertension even in the first place. There is a 2 to 6-fold increase in hypertension with overweight, fairly linear weight dependent. And conversely, as little as 5 to 10 pounds of weight loss can lower blood pressure. Mild to moderate aerobic activity is associated with a 5 to 8 millimeter drop in blood pressure. And conversely, lower physical activity levels are associated with a greater de novo incidence of hypertension. More than 3 drinks daily for women, in contrast to 2 for men, associated with an increase in blood pressure and decrease in alcohol intake can lower the elevated blood pressure. Modest decrease in sodium intake associated with a lowering of blood pressure, and of course, conversely, eating too much sodium will raise the blood pressure. The interesting feature is that there is less hypertension in premenopausal women compared with age-matched men, and the question for that is that an impact of sex hormones on the brain sympathetic nervous system? Because as you know, after menopause, blood pressure rises far more steeply in women than in comparably aged men. So certainly some suggestion that hormones are important. It's likely a combination of risk factors that will result in the development of hypertension in women, but obesity appears to have the greatest impact. So it's not surprising that with the obesity epidemic we're seeing today in the United States, we're seeing more hypertension and more hypertension in women. So we really have a multifaceted approach to prevent hypertension in women in the first place. And that is a normal BMI, a diet that favors fruits and vegetables and limits calories, regular physical exercise, limitation of alcoholic intake, and something I haven't discussed, limiting the non-narcotic analgesics, because many of these are associated with raising the blood pressure. Now what I'm going to do for the remainder of the time is go through the lifespan and show you how different hypertension can be at different stages of a woman's life. Very low hypertension prevalence in children and adolescents, about 1 to 5%, quite unusual. But pre-hypertension prevalence begins in the teenagers, and in girls 10 to 17 years of age, almost 16% of them have pre-hypertension. And the prevalent risk factors for that pre-hypertension are obesity and a family history of hypertension. So that our pediatric colleagues and our family medicine colleagues should be working to limit the features that will cause the pre-hypertension to progress to hypertension and encourage diet, exercise, alcohol limitation. But, in adult cardiology, when we see patients with hypertension, it's typically primary or essential hypertension. In children and young adults, it's more often secondary hypertension. So that for us as adult cardiologists, when we see teenage patients, we have to go back to our list of what are the causes of secondary hypertension, because we're much more likely to find them present in a teenager. And renal artery fibromuscular dysplasia, by far away the most common, and 90% of those occur in girls. Hyperaldosteronism, hypothyroidism, the combined hormonal contraceptives, all of the illicit drugs are associated with hypertension. A large number of diet and herbal products. And I have to ask you to remind your patients that if they take herbal product A from the drugstore and they go back for that same product A the next month, it may not be the same. They are not at all regulated, and there is no assurance that it is the same substance and the same dosage, which makes most of these over-the-counter herbals risky. Pheochromocytoma, a common secondary cause for hypertension, and the one that we're always taught thou shalt not miss, and that is aortic coarctation. So all of these, really, you have to go down the check mark, either for the physical findings or for the laboratory findings, to be sure that these are not present in the teenage or young adult woman in your practice. Interestingly, non-Hispanic African American women are more likely to have hypertension with pregnancy, and that begins to show up even in the teenage pregnancies and certainly later on. And there are major socioeconomic factors, again, going back to the lecture that we heard yesterday, the wonderful lecture, because without access to health care or insurance, or for those women who are living below the poverty level, they are less likely to take their medications as prescribed, and often will try to reduce the financial burden by taking either fewer medications or no medications. So I think that is a question to ascertain in the office, because in contrast to 15 or 20 years ago, there are many very inexpensive antihypertensive medications. And if your patient has financial problems, you can go to specific medications that cost very, very little. I never thought I would hear myself ever saying anything good about Walmart, but I do have to say that Walmart has allowed my patients to get $4 a month antihypertensive medications, and has essentially been the catalyst for many of the drugstores and many of the grocery stores to do the same. so that this is accessible to patients. And we really have to query whether finances are a problem and make our choice depending on what the patients can afford. Now, hypertension in pregnancy is really an underappreciated risk by adult physicians. And the reason is that in so many systems, the obstetrical record is kept entirely separate from the rest of the medical record. And if you assess risk in women, you must take a detailed pregnancy history and a history for pregnancy complications. Hypertensive disorder is the most prevalent cardiovascular disorder in a pregnancy, and they're present in 5 to 10% of US pregnancies and appear to be increasing with the obesity epidemic. The American College of OBGYN classifies hypertension in pregnancy 4 ways. Chronic hypertension is a blood pressure more than 140/90 that is present before the 20th week of pregnancy, meaning that the patient comes to the pregnancy hypertensive. Preeclampsia is hypertension, but not even necessarily proteinuria. But if the proteinuria is not there, we often see the combined syndrome of thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, and cerebrovisual symptoms. Once you have the onset of grand mal seizures, it's no longer preeclampsia, it's full-blown eclampsia. And then just gestational hypertension is hypertension that appears de novo after the 20th week of gestation. So these are important differentials because their prognosis is different. As I've said, chronic hypertension is present in about 1 to 5% of pregnancies, gestational hypertension in 6 to 7%, and preeclampsia, eclampsia in up to 10% of pregnancies. Preeclampsia has increased by 25% in the last 2 decades, and we're not sure whether it's better recognition or whether it's really increasing. But this is a very serious problem for the obstetrical community. It's probably among the major causes of maternal morbidity and mortality, disproportionately affects African Americans, and it seems to be more extreme at the extremes of reproductive age, the teenagers and the late 30s pregnancy, much more liable to preeclampsia. It's more prevalent when there are underlying cardiovascular risk factors. And there are 2 new things that have happened just in recent years. The U.S. Preventive Services Task Force recommends screening for preeclampsia by measuring blood pressure at every obstetrical visit. And that may be one of the reasons that we're picking up more and more of this hypertension in pregnancy. Now, how do you treat hypertension in pregnancy? First, as you know, there is a reluctance to do any drug testing during pregnancy. So if you're from hospital A or B or C, the preferred drug during pregnancy will be very different because it's the experience of that hospital, it's what has been safe. It doesn't mean they're right and the other one is wrong. As I'll show you, there have not been that many head-to-head comparisons. But there is something new. The American College of OBGYN recommends low-dose aspirin to prevent preeclampsia in high-risk women. And the high-risk women are those with a family history of preeclampsia, who have had prior preeclampsia, or who have a burden of coronary risk factors. So these women get low-dose aspirin throughout their pregnancy, and the results have been very, very satisfactory. Now, what did we learn in school? We learned that blood pressure changes during pregnancy. With the increase in cardiac output and the vasodilatation, typically the blood pressure will drop during pregnancy. But there is no evidence-based recommendation for tapering blood pressure medicines during pregnancy, and there's no specific goal for therapy. It's just that there are not the data to define these. ACOG recommends maintaining a systolic blood pressure between 120 and 160. It's a huge range, and a diastolic between 80 and 105. ACOG only recommends treating severe hypertension. That's a systolic over 120 and a diastolic over 110 to reduce pulmonary edema, stroke, and placental abruption. But a very conservative approach to treating mild to moderate hypertension because of the fear, and it's a real fear, that aggressive blood pressure lowering may compromise the fetal circulation. When I see pregnant hypertensive patients, I do not let them get to 160 over 110. I will typically keep them in the range of about 140 over 90 and warn them that if they have any kind of an illness, a gastrointestinal illness, or get dehydrated, that they need to drink fluid, because that will decrease the circulating blood volume and may compromise the fetal circulation. But you're really between a rock and a hard place in treating hypertension during pregnancy. There was one randomized controlled trial of tight blood pressure control, which was diastolic of 85 compared with less tight, a diastolic of 100. And there was no difference in the maternal and fetal outcomes, but the ones who had less tight diastolic pressure control had much more severe maternal hypertension, which is why I generally try to keep the diastolic around 90. Now, you have to remember that all antihypertensive drugs cross the placenta, which is why there has been such a reluctance to test them in patients. And there has not been any randomized controlled trial about efficacy and safety. Until this past June of last year, the FDA had risk categories for drugs during pregnancy. A meaning it's safe and there are almost no A drugs. B meaning enough drug has been given that there have not been adverse effects. C meaning not as much evidence, and D, you shouldn't give it. But they didn't like their own classification, and as of last June, the ABCD is gone. If you go online, you will not find that categorization, and what you have to do is to look at each drug and see what they list as benefits and risks. But in general, the drugs that I tend to go with are hydrochlorothiazide, chlorthalidone, and methyldopa, because previously those were class B, and that means there has been the largest safety experience with them. Nifedipine, labetalol, and hydralazine are category C under the old system, but many of the contemporary drugs have not even been rated. So I think this does become a problem. Again, one randomized trial comparing labetalol with nifedipine, there was no difference. They both control the blood pressure to target. And also remember that, low sodium is a cornerstone of our management of hypertension, but ACOG recommends against a very low sodium diet, again, because of the risk of a low intravascular volume. Because here you have to watch the blood pressure for the mother, but the perfusion pressure for the placenta and the fetus. Hypertension in pregnancy has some very serious long-term implications. It increases the risk of future cardiovascular disease, diabetes, and chronic kidney disease. We're not sure whether preeclampsia is an independent risk factor for cardiovascular disease or a marker for pre-existing disease. And I think it's a marker because of the women who come to the pregnancy with a plethora of coronary risk factors, those are the ones more likely to develop preeclampsia. Now, we were taught in school preeclampsia subsides with the delivery of the placenta because it's really a placental disease. But it doesn't subside because it's a vascular disease. And the endothelial dysfunction with preeclampsia may persist postpartum. It can be measured by arterial constriction studies. And it's associated with an increase in coronary calcium. We heard about coronary calcium yesterday. Coronary calcium, to me, is atherosclerosis, which means, to me, that the endothelial dysfunction of preeclampsia is a precursor for atherosclerosis. But with all of this, we have no specific recommendations for long-term surveillance. I will tell you that at our Women's Heart Center at Emory, what we do is one of our cardiologists goes over to the OB side and meets women who've had preeclampsia in the preeclampsia 6-week follow-up clinic, introduces herself, talks about coronary risk factors, talks about the importance, since they are prone to coronary disease, of physical activity, of not smoking, of healthy diet, etc., and we'll give them an appointment to follow up, because some of the risk factors can appear within 6 to 12 months after delivery in young women. Now let's go to the other side of the hormonal status and go to menopause and hypertension. And surprisingly, the role of sex hormones is uncertain. What we see, as I've told you, is that premenopausal women have a lower blood pressure than age-matched men. But postmenopausal women have a higher blood pressure and a wider pulse pressure, so mainly systolic hypertension, than age-matched men. But we're not sure whether it's an effect of age, whether it's an effect of BMI, or whether it's an effect of sex hormones. And it may be a combination of all three. But the features that seem to influence hypertension in the menopause, certainly a genetic predisposition. But hypertension is a multi-genetic order. It's not one gene for hypertension. We see it with aging and changes in the vasculature, obesity, an important contribution, arterial stiffness due to atherosclerosis, oxidative stress, which is imparted by all the risk factors, sex hormones, age-related impairment of endothelial function, and certainly salt sensitivity. What we tend to see is that hypertension, as I've told you, is higher in men until about age 40, 45, and then it stays stable across the lifespan. The women who have lower hypertension, premenopausal, have it increase rather precipitously after middle age and continue to increase well into the 80s, so that more older women than older men have hypertension. As a matter of fact, most women in this country will develop hypertension in their lifetime if they live long. So I think that this is the basis for the recommendation that even if you've been normotensive through all of your first 20, 30, 40, 50, 60 years, that blood pressure still be measured on an annual basis to screen for the development to know of hypertension. Menopause-related hypertension seems more related to BMI and to aging than specifically to the ovarian failure to secrete estrogen. And what we see is that those women who are taking menopausal hormone therapy doesn't significantly decrease blood pressure, and some preparations actually increase blood pressure. Now, here is where we see the major amount of hypertension numerically, and that's hypertension in the elderly woman. I've told you that hypertension prevalence increases markedly with aging, and for the octogenarian women in your practice, their prevalence of hypertension is about 90%. So 9 of 10 women over age 80 walking into your office will have hypertension. So that should be a big part of your practice. It has the highest population attributable risk for dementia. And here is where I get the attention of my patients who do not want to take blood pressure medicines, who say, well, I'll exercise, I'll watch the salt. A pre-hypertensive blood pressure at age 50 predicts decreased cognition a decade later. Pre-hypertensive blood pressure at age 50 predicts lowered cognition a day later. And your patients will listen to that, and they will watch their blood pressure, and they will watch their salt, and they will measure their blood pressure and bring you a record of it. We don't do as well with blood pressure control in older women. In the Women's Health Initiative, remember, these are health-conscious women who volunteered for a research study, 41% control, pretty low at age 50 to 59, compared with 29% in the 70s. And what we see is that the decrease in endothelial function seems to occur later in women compared with men. And the impact of that is important in something that we do in clinical practice, and that's exercise testing, because impaired endothelium-mediated vasodilation in the elderly, actually both women and men, but more prominent in women, especially during exercise testing, may give you an exaggerated increase in blood pressure. So very often put the woman on a treadmill and the blood pressure will just shoot up, and this is impaired endothelium-mediated vasodilation. But that occurs during the day with any kind of activity, not just the treadmill. So it's important that we control that blood pressure. And we heard all the guidelines, and neither a blood pressure threshold for initiating drug therapy nor a goal is firmly established for elderly patients, men or women. And we had the discussion late yesterday in terms of measuring the blood pressure seated and standing, being careful of orthostatic blood pressures, and my preference for the patients who have orthostasis that a beta blocker be one of the drugs, simply because it is the only antihypertensive that does not have an orthostatic effect. But actually, there's no pharmacologic therapy that is most beneficial for older women, except maybe the thiazide diuretics, because as you know, thiazides decrease calcium excretion and may prevent osteoporosis. But among the other drugs, there is none preferable. We know that more women than men will have an ACE cough. We know that more Black women than white women will have an ACE cough. So when I start a Black woman on an ACE, I tell her a sizable number of people will develop a disturbing dry cough. If that happens, call me and I will change your medicine. I don't want her to wait 3 months not taking the medicine because of a cough. And then we have to think that there are subgroups of elderly women, the very frail, those with severe chronic kidney disease, where hypertension treatment may not be beneficial. And what we say is, what are the goals of such therapy? And for the elderly, frail patient, men or women, but particularly the women, sometimes we have to go the route of de-prescribing and saying, is this medication, is this antihypertensive medication doing more harm than good? We've gone over a lot of territory. Let me summarize. Hypertension affects women in all phases of the life cycle. It is a very important contributor to the morbidity and mortality of women. With incident hypertension, women are more likely to develop chronic kidney disease and less likely to develop other cardiovascular outcomes than men. But women have an increased prevalence of concomitant cardiovascular risk factors requiring treatment than men. So as you treat the hypertensive woman, be sure that you're paying attention to the diabetes or pre-diabetes, to the hyperlipidemia, because this deadly constellation is very common, and that you equally treat all risk factors. And I thank you for your attention.